Advances in medicine have propelled healthcare to new heights. But are we getting too much of a good thing?
People are sometimes being exposed to tests, treatments and procedures that can sometimes actually be harmful.
Too much medicine can actually cause harm and angst and confusion.
There's increasing concern that screening for certain cancers and overprescribing pills may be doing more harm than good.
Medicine should probably be leaving the well to be well instead of constantly trying to find something wrong with them.
It's a problem of doctors not understanding, not knowing, not doing best practice.
The hardest thing to do in medicine is to do nothing.
In this special Catalyst investigation, I speak to doctors who say our relentless pursuit for good health could be making people sick.
We've all heard the adage, prevention is better than cure. But does it always apply?
Prevention is better than cure is a terrible adage in a way because it makes so much sort of obvious sense that no one really interrogates it properly.
Dr. Iona Heath is the former president of the Royal College of General Practitioners in the UK. She says valuable resources are being wasted on unnecessary tests on the worried well.
We have shifted a massive amount of resource within health services from the sick to the well, and probably harming the well in the process, or at least some of them, and certainly harming the sick, because if you take resources, they have to come from somewhere.
The issue has garnered international attention, with the British Medical Journal launching a campaign against too much medicine. Its aim is to reduce the overdiagnosis and overtreatment of conditions. One example is the controversy over mass screening of women for breast cancer. Awareness campaigns promote the idea that screening saves lives.
There's no doubt that cure rates in all cancers are improved with early diagnosis.
Professor Sanchia Aranda from Cancer Council Australia supports breast cancer screening because it detects abnormalities that cannot be felt by physical examination.
It can find breast cancers as small as a grain of rice, which is really much smaller than anybody can detect by feeling or on any sort of, it doesn't cause changes in the breast.
In Australia, women between 50 and 74 are encouraged to get free mammograms every 2 years.
About 21 to 28% of breast cancer mortality reduction are due to breast screening. Breast screening is one part of the improvement in survival, but it's not the only.
But recently, this claim has been challenged by a Canadian study of over 80,000 women. Half participated in mammogram screening and half did not. After 25 years, it showed that mammograms did not reduce the risk of death from breast cancer. Undoubtedly, there are individual cases of lives saved, but it made little impact on the overall survival rate of the population. Therefore, it has raised concerns about the value of mass screening as a public health initiative.
When they started out on this screening program with the best of intentions, good people trying to save people dying from a horrible disease, they didn't know that this was going to be there.
Dr. Heath says it may be a fault in the design of breast screening programs.
Screening only ever catches a certain virulence of a cancer, if you like. It catches all the ones that are growing really slowly that would probably do nothing in a person's lifetime. That's no good to anybody. It catches the people on the medium trajectory, and that's where the possibility of benefit is, but they're relatively few. It does nothing for the people, mostly young, who have really, really virulent cancer, who are the real tragedies of breast cancer. It doesn't catch those because that is developing so fast. It comes up between screening intervals or before screening exists. And so that's the other thing that upsets me about screening, really, is the kind of false promise that if you do what you're told, you'll be prevented from getting this dread disease, and that's not true.
Much of the uncertainty in breast cancer screening surrounds an abnormality called ductal carcinoma in situ, or DCIS. Oncologist Dr. Ranjana Srivastava says DCIS now accounts for about 25% of abnormalities on screening mammograms.
DCIS is not cancer. It is a precursor to cancer. Many of these abnormalities might never cause a woman any harm, but at present it seems to be difficult to know which women they might be.
Currently, most women choose to have surgery to remove DCIS. However, a recent study of over 100,000 women showed these treatments did not prolong their life.
They found that the risk of a woman dying from breast cancer after she had undergone either a lumpectomy, a mastectomy, or in some cases a bilateral mastectomy was close to the same as the likelihood of any woman dying in the average population.
Pathologists can try to predict which DCIS might develop into invasive cancer based on whether its pathology is low or high-grade risk. But there's no certainty. It was this kind of uncertainty that unsettled Henriette after her mammogram found she had DCIS.
I understood fully that it wasn't cancer at that time, but there was no guarantee that it will not get cancer. And what was very important for me was scientifically they could not guarantee me any time frame.
After consulting with her family, Henriette decided to have a mastectomy.
Was there ever any point in your mind where you thought, it's not cancer, so let's not jump to surgery?
Not at all. I made a decision immediately. Why would I now complicate my life further by making a simple decision for a simple mastectomy, and I'm a healthy person afterwards?
Some might say that a mastectomy isn't a simple thing to go through for a woman.
I think it can be very emotional, but there are a few factors that one must take in consideration. The age of the person, the relationships that she's in, her self-confidence. I would say it differs from person to person. For me, it was no problem at all. My husband has got a medical background. For him, it was important to support me in my decision and also realize that that is the best thing for us.
So no regrets?
No regrets at all, no.
While Henriette is comfortable with her decision, grappling with the concept of whether to treat DCIS is confusing to many women.
I think we really do have to look at how we name this. Do we rename DCIS as something else? Do we counsel women before they have a mammogram that the finding of a DCIS is not the same as the finding of an invasive breast cancer?
We don't know what we're doing because they're not frankly cancer. So do you go cutting breasts off, and what do you do in this situation? It's like a Pandora's box. Once you've opened it, you can't close it again.
Increasingly, the medical community is beginning to understand the value of watchful waiting. So you say to somebody, we will watch and wait to see what happens. I think intuitively it doesn't sound right to patients. By its very name, carcinoma, it creates a tsunami of doubt and fear and anxiety for the patient's lifetime.
It would be fair to say that the jury is still out on what the best treatment is for just DCIS if it is present in the absence of an invasive breast cancer. And trials of treatments probably are justified in those women because it is unclear.
The debate about overdiagnosis in current breast cancer screening programs continues around the globe.
I suspect there are very few women who do benefit, but it is the cost of harm to a much greater number of women. Now, what that balance is, how do we do this with human lives? How do you sum this? one woman who doesn't die of breast cancer against 100, say, who are harmed in some way or another by the screening process. How do you make that equation? I can't make that equation. We don't have a way of talking about human life in that way, and I'm glad we don't.
We need certainly to invest more in research that helps us to understand the biological nature of cancer specifically. The critical thing is that the women make informed decisions, that they're given appropriate information on what their options are and what risks they are prepared to take, because it really is a very personal decision.
Now, it's not just screening programs that have doctors debating. A new report from here at the Grattan Institute confirms that thousands of patients have been receiving unnecessary and sometimes inappropriate treatments while in hospital.
Economist Stephen Duckett co-authored the report, which looked at a range of surgical procedures.
We identified in just 5 examples more than 5,000 unnecessary procedures happening every year. This means there are probably 5,000 people who need surgery who aren't getting it. This is a serious misallocation of resources.
An example in the report is the claim that of all the women who had their ovaries removed, more than 50% of them were unnecessary.
This was a situation where a woman has a hysterectomy and just for the sake of it, they decide to take out her ovaries as well. And there's no evidence that this has any benefit to the patient. And of course, every time the procedure is lengthened, every time a woman stays longer in the operating room, there's an extra risk.
Another concern surrounds the excess of knee arthroscopies.
The report showed a surprising amount of ineffective care. One procedure we looked at, for example, was arthroscopy for osteoarthritis of the knee, and we found that occurred 15 times a week, which, you know, bearing in mind this is something that shouldn't occur at all, is a high rate.
Are there financial incentives for providing these treatments?
Yes, financial incentives obviously impact on everybody, but there are a host of reasons why people might do these operations. One of them may be they don't know, one may be they think they've tried everything, and one may be financial.
Are patients putting pressure on the doctors to perform these treatments?
I think there is a strong element of patient pressure in all of this, that they often say to a doctor, look, you know, you must be able to do something. And if the doctor says, look, we just want to wait, they might say, well, I'll go and see another doctor who may do something. And so there's a lot of hype in the media that doctors can fix everything, and the reality is they can't. Sometimes there's nothing they can do, and we just have to accept that.
One of the major contributors to the overuse of treatments is a phenomenon called diagnosis creep. It's when the threshold for treating a disease is lowered, so more and more people become eligible for that treatment, simply because of a change in the way they define the disease. Then healthy people become classified as patients and often end up on pills for the rest of their lives.
Take the definition of high blood pressure, for example.
When I was a medical student, we used to define a normal blood pressure as being under 100 plus the patient's age for the top number and 100 for the bottom number. Nowadays, it's 150 over 90 or 140 over 80. And by changing that threshold, you include millions more people in the range of abnormality and in the market for antihypertensive medication.
This has raised questions about whether people with mild hypertension would benefit from blood pressure medication. While people with diabetes benefit, a Cochrane review showed that most people with mild hypertension don't.
Treatment of mild hypertension has had no benefit on either morbidity or mortality, and that is the vast majority of people worldwide on treatment for hypertension.
Another area of medicine debating the issue of overdiagnosis is the field of psychiatry. In recent years, there's been a monumental effort to destigmatise mental illnesses like depression. Psychiatric epidemiologist Dr. Melissa Raven has studied the rising awareness of depression as a result of campaigns in the 90s.
That campaign was really quite successful. The implication was very strongly that antidepressants were the solution to the high rates of depression in the population.
It coincided with the introduction of Prozac onto the US market in the late 80s. It was dubbed a breakthrough in the treatment of depression. The subsequent rise in the use of these medications has been staggering.
There has been a popularisation of depression, and I think that that's really problematic to suggest that a very significant proportion of the population has depression or some other mental disorder, and that really raises issues about how we define depression and how we define normality.
Psychiatrist Professor Gordon Parker says the incidence of depression has increased significantly over the decades.
In the 50s, when the first antidepressant was discovered, lifetime risk of clinical depression was about 5%. Now it is 30% up to 80%. Why has that come about? Mainly because the DSM system has progressively dropped the boundary of what is clinical depression.
The DSM is the American system for classifying mental illnesses. It has attracted widespread controversy for its persistent widening definition of depression.
Depression can exist as a disease, as a normal reaction, and it can be blurred into sadness and grief. Unfortunately, the last 30 years, we have seen all those various states homogenized into, if you like, a single category. And so it's this blurring of boundaries that has created the confusion.
In Australia, we're now ranked second of all the OECD countries for the use of antidepressants. Antidepressants do have their place, but Professor Parker says the issue is that there's a mismatch between overdiagnosis and undertreatment.
Many people are concerned about what's seen as the overprescription of antidepressants. And there are arguments that certainly support those concerns. I'd also argue that many people with melancholic depression who do well with antidepressants unfortunately don't get them, so there's also underprescribing. What we need to do as professionals is to ensure that the boundaries are reasonable and relevant, and unfortunately we're not seeing that. We're seeing a great merging of what is true clinical depression with normal states of sadness, and that then leads to quite inappropriate use of antidepressant drugs.
Today, one of the most widely prescribed drugs in the world is statins. They lower cholesterol and the risk of developing heart disease. Statins are justified in those with existing heart disease. But there's been anger over a recent decision in the UK to expand the use of these drugs in healthy people.
It's such a huge controversy. It's a classic case in a way, you know, that you take this tablet, it'll stop you dying of heart disease, and no acknowledgement that there are significant side effects.
Last year, a UK committee decided to drop the threshold for prescribing statins. It used to advocate them for people with a greater than 20% risk of heart disease, but now they've halved it to just 10%. It's reported to result in millions more healthy people taking statins. Doctors objected to the change. A survey showed 2/3 of GPs in the UK would be disregarding the advice to offer statins to people at the newly stated threshold of 10%.
Doctors wouldn't take statins at the level that's recommended. I mean, if you ask a group of doctors whether they'd take statins at that level of risk, the vast majority say no. So why would they want their patients to take it?
So if doctors aren't willing to take the medications, why are the guidelines advising that patients should be taking them?
It's a very good question.
Despite the backlash, the UK committee defended its decision to broaden the use of statins. claiming that it would save 8,000 lives and prevent 28,000 heart attacks per year. But recently, a controversial review showed that those without heart disease taking a statin for up to 6 years only increased their lifespan by a few days. This prompted the BMJ's editor-in-chief, Dr. Fiona Godley, to call for recommendations for the prescribing of statins to be reviewed. It remains to be seen whether Australia's guidelines for prescribing statins will change to align with other countries.
Concerns have been raised about the impartiality of those who set the medical guidelines for statins. In the UK, it was revealed that 8 out of 12 panel members who changed the recent guidelines had financial ties to the drug manufacturers.
But the UK committee denied that the conflicts of interest influenced its decision to expand the use of statins.
Fundamentally, it's the commercial imperative. The global pharmaceutical industry sales are supposed, for the first time in 2020, to top $1 trillion American dollars. That level of predicted profit relies on us all taking more and more tablets. Now, if you want to make a health-related profit, you're going to make a lot more money if you develop a drug to keep well people well than if you develop a drug to treat sick people, particularly very sick people, because they die and don't need your medication anymore. So nowadays, pharmaceutical companies invest more in preventive medications because the market is so much huger.
Good morning. How are you today?
Not too bad.
Dr. Srivastava says elderly people are often on multiple medications, many of them unnecessary.
We've stopped your blood pressure tablet because your blood pressure has been fine, and we felt that the kidneys were getting a bit under stress. We also stopped the Panadol.
It's a problem known as polypharmacy.
8 tablets a day of Panadol before. That's a lot of pills to take. On the general medicine ward where I work, there would traditionally be multiple patients who are victims of polypharmacy. Common drugs that people have complications from include drugs for anxiety and depression, sleeping pills, antipsychotics, blood pressure tablets, proton pump inhibitors, or acid reflux.
She says a lack of continuity in healthcare is to blame.
Modern healthcare is extremely fragmented. And I think time and time again, I see patients saying to me, how is it that you don't know what my nephrologist and endocrinologist and orthopedic specialist are up to? And the answer is because they may have been seen in different parts of the system. People don't necessarily communicate to each other. And there is no central repository of all this information.
Hospital Registrar Dr. Cameron McLaren says many of these problems could be alleviated with better communication between doctors and patients.
These days, doctors aren't the only source of information about health. We're dealing with a much more educated population, a much more questioning population, and doctors are learning to deal with that new population. I think times are shifting a little bit, times are changing, and the communication skills that are becoming more entrenched in our profession are helping to guide people or doctors through that transition.
According to the Centers for Disease Control and Prevention in the US, drug overdose was the leading cause of injury death in 2013. And of these, just over half the deaths were related to prescription pills.
Sit on a CT, I don't think we need a CT.
Dr. Srivastava says more doctors need to practice the art of deprescribing.
Deprescribing is something that I think should go on every bedside, at every ward round, every day. And it essentially means looking at a drug chart very carefully and seeing what justification there is for having each one of those drugs in the doses and at the frequency that they're being prescribed at. I think it's absolutely incumbent upon doctors to look at those drugs and ask themselves, can this patient be off this drug? And then take the time to explain to the patient why they don't need the drug anymore and lower their pill burden.
So what can be done about too much medicine? An international initiative called Choosing Wisely is helping doctors and patients make more informed choices about medical therapies.
What this campaign seeks to do is actually improve the quality of care, starting a conversation about what's appropriate and hopefully reducing people's exposure to things that are of no proven benefit. That's where this initiative is seeking to effect a bit of a culture shift in terms of changing people's thinking and realise that while tests and medicines are great in managing conditions, there is a downside, and so you want to make sure that the upside outweighs the downside.
Choosing Wisely began in the US in 2012. It expanded to Canada and now into Australia.
Overwhelming feedback was that this was something that was needed and that Australia and Australians would benefit from having.
Have you received any resistance from doctors that perhaps might think patients shouldn't be questioning their judgments?
There's probably some reticence from some doctors because they're the experts in their area and they don't want people to be coming in and second-guessing everything that's going on. But what we're hopeful of and what the initiative seeks to achieve is to actually support the doctors in terms of raising awareness around different tests and treatments that sometimes patients might have an expectation that they should receive, and by making public the evidence that indicates that it's not always appropriate.
Since the Choosing Wisely campaign began, the Royal College of Radiologists has raised concerns about the overuse of X-rays and CT scans for assessing lower back pain. Also, the Royal College of General Practitioners has expressed concerns about the overuse of proton pump inhibitors for acid reflux and calls for more judicious prescribing of blood pressure medication.
How do you deal with the challenge where patients may feel the doctor might miss a diagnosis if they scale back on testing?
The recommendations that are being identified as part of Choosing Wisely aren't things that we should never do, but they're things that should be part of a conversation between a doctor and the patient about whether that's the best thing for that patient right there at that time.
With better information, the patient and the doctor can be empowered.
I think people, as consumers, have to understand their own health and then become advocates for their own health. If I were a patient and I was being prescribed a drug, a blood test, a biopsy, whatever it was, I think some of the questions that I would like to ask include, why is this necessary? What happens if I don't have this? Are there alternative ways of managing this? If I need to take a drug, are there some lifestyle measures that could be tried first? And I think, all that sort of stuff really requires some health literacy and a belief that it's not simply about trusting your doctor, it's about taking charge of your own health. It's a relationship, and that relationship means that both people have to play their part.
There you go. Just double check that it's all right.
Thank you.
For more information about the studies referred to in our program, you can go to our website.